Everyone. I feel very awkward because I can't see you, but I'm going to believe that you are there. I hope everyone is one by one joining the webinar and settling in. First of all, I'd like to introduce myself. I'm Jordana McClune. I work at the Kids Cancer Centre at Sydney Children's Hospital. And I'm here tonight joined by my friend and colleague, Dr. Kate Hetherington, and we're really looking forward to, thank you for your warm and welcoming invite to be part of this webinar series that you're doing. We're very excited to be joining you from Australia and sharing our knowledge and our thoughts across to our friends in New Zealand, who I still am not sure if you're there. But anyway, I will continue. So now let me share my screen with you so that you can see, whoopsie, backwards. Okay, oops, but now I've lost my Zoom. Okay, so let me go to Zoom. All this technology, share screen. Here we go. And then I want to make this big as well. And I want to, oh gosh. Can I get some sort of confirmation from anyone out there? Oh, perfect. Okay, I can see now. Okay, so again, I'm going to proceed and believe that you can all see my screen. Somebody please speak up if you can't.
Yeah, we can see you. Just
excellent, thank you.
Yeah, and a couple of people have text messages saying that they can see. So.
Okay, wonderful. Thank you, everyone. Much appreciated. Also, Kate and I are very open to questions. We'd love to hear from you. We love hearing back from the parents. But maybe because of this webinar type format, we might wait until the end of both Kate and I talking. So if you can just try and remember your questions, and then at the end, we'll open it up for discussion. My understanding is that the majority of the audience is parents who have children who have survived a diagnosis of cancer. But I also understand that we have a couple of parents in there who are bereaved or have children still on treatment. So we welcome you as well, and we hope that you can find something in this talk that's useful for you. So tonight, Kate and I would like to focus on childhood cancer, the survivorship period, and the late effects that can emerge during that period, in particular, the psychosocial late effects. So, as most of you are quite well versed, I imagine, about childhood cancer by now, you probably have a great understanding that due to the toxicity of the treatments that we give the children, it can be very damaging to their developing organs and their little bodies. And as a result, many of them develop late effects. This can happen years or even decades after. Often we find that there's a relatively healthy period, and that then, 20, 30 years later, potentially, some of these things, late effects, start to develop. These can include growth and development, organ function, things like cardiovascular disease, endocrine disorders, neurological impairments. It can affect their fertility and their reproductive systems. And even some of the treatments we gave them are somewhat carcinogenic. They can have a recurrence of the primary cancer or develop new second cancers. So these are the physical type late effects that often occur. But today, as I said, we want to focus in on these psychosocial late effects. My talk will cover mainly a discussion of these, their prevalence, risk factors, that sort of thing, and then Kate might continue on and talk a little bit more about what we're trying to do to support you guys. And so also I just want to point out, so that we're all on the same page, the psychosocial late effects aren't just those mental health psychological ones, such as anxiety and depression, some post-traumatic stress disorder, but they also include the really social aspects, and I think a lot of the time that's forgotten. Things like the impact on education and employment, more so in the US, but becoming increasingly more so in Australia, health insurance, social interactions, management of those chronic symptoms, physical and body image. These are all the things that we put in that psychosocial domain. So now also, I understand that when you go through and you list risk factors and prevalence and all the things that might happen, it can seem quite overwhelming. And so from the outset, I just want to say that not everything happens to everyone to its most severe level. But at the same time, it is important to educate ourselves about psychosocial late effects, to open the conversation and have discussions about it, to feel that it's very normal after having gone through cancer treatment to have things that stay with us in the survivorship period. So this should be a discussion where we learn and we recognise the support we still might need and how that's very normal. But please let me know if it's at any point becoming quite overwhelming as I list and explain things. And for that very reason, I want to acknowledge up front that surprisingly, it can have childhood cancer, a lot of people are saying it can have a very positive impact on their psychosocial and mental health. Survivors often experience positive life changes. There's some post-traumatic growth or benefits, meaning finding, the galvanization of relationships, the development of compassion. There can be some really positive outcomes. That being said, it's important to acknowledge also the negative impact that it can have and how long that can extend for into the survivorship period. Or, as I mentioned as well, after a relatively smooth sailing, healthy period, it can develop years later, and that's very normal also. So if we look at what I have up on this slide, we've got health-related quality of life, and we know that this does decrease as survivors age. There's quite an interesting slide, quite an interesting piece of data we have that as survivors get more further and further from and less engaged in long-term follow-up care, this is actually the time that more and more of these late effects develop. And we're really trying to create care pathways that will change that. Anxiety and depression, 41% experience anxiety more than 30 years later on, and 34% report depression up to 7 years later. And this is in contrast to around 17% lifetime prevalence in the general population. Lower levels of distress and PTSD, post-traumatic stress disorder, but still around 10% of survivors are experiencing this 7 to even 25 years later. And some body dissatisfaction is reported also. Long-term survivors report lower self-worth, more negative body image perceptions, that sort of thing. And again, the impact that poor psychological health can impact on their social functioning. So it has been reported in the literature that survivors often report fewer or poorer social relationships, maybe some problems at school, or they might find peer relationships difficult. And they might have concerns about future relationships, develop fewer intimate relationships, and be less likely to marry. And again, it's important to recognise how our psychological health and well-being can impact our physical health. So, depending on your psychological well-being, you may demonstrate increased risky behaviours. Poor psychological health is related to increased health service use, poor medication and treatment adherence, and increased and is associated with increased healthcare costs. Recently, our group did a huge study across Australia and New Zealand. You can see Starship in Auckland and Wellington and Christchurch all included there. We had participation from all 11 Australian and New Zealand survivorship clinics. We interviewed and sent surveys to over 600, we had over 636 respondents. And what we found in the Australian and New Zealand context was that 42% reported anxiety or depression. Now, these are parents of children and also childhood cancer survivors who have grown up and are adults now themselves answering these surveys. So it is very, very common and very, very normal to experience anxiety or depression in the survivorship period. But it's also important to remember that in different ways, the general population also experiences anxiety and depression. As you can see here, in fact, childhood cancer survivors actually reported less anxiety and depression than healthy controls in each of these age brackets, except for the 31 to 40-year-olds. So that's nice to see. But if we look more at cancer-related anxiety, we're seeing really high levels. You can see here in the first graph, we've got second cancers. The yellow bars are if the survivor thought they were at risk of developing a second cancer, and the blue bars are looking at how anxious they were about it. And these things are often highly correlated. But you can see that by the time they were sort of 30 to 50 in that sort of age bracket, it's around half of them that are feeling quite anxious and feeling quite at risk of developing cancer, second cancers. And then the second graph looks at late effects, their perceived risk of developing late effects and how anxious they are about it. And again, this is sitting, around 50% of survivors do think they're at risk of developing late effects. They're feeling anxious about it. And in the older age bracket, it's like 2/3 of survivors are feeling quite anxious about the development of late effects. So I think it's very important to understand that it is a special and unique cohort that we have here, and it isn't sometimes this general anxiety and depression that healthy people might be experiencing, but it can be quite cancer related. But despite this, only 22% reported receiving psychological support. So I think this really shows this is an area that we can do a lot better and we need to provide more. If you look at the top 10 late effects that were reported, maybe, I don't know, I'd love to hear later if you all relate to any of these. I relate to the top one of fatigue, but it's only because I have small children. And you can see that emotional issues are right up there as one of the top late effects that our survivors are reporting. And about a third of them are reporting emotional late effects. And in terms of information needs, this is all in the psychosocial domain. They receive adequate information about their physical health, about their medical conditions, but still survivors are saying we want more psychological support. We need to understand how we can just manage fatigue and pain. We need more advice around our finances and employment situations, our work and education, and some relationship advice as well, because it's still impacting us. This is a father of a 15-year-old, and he said, I don't know how to change where my little, post-treatment, possible psychological issues are not explored at all. This is where I think the greatest need is. That's a nice little quote from our study. Yes, in terms of support needs, over half wanted access to a psychologist and a third wanted access to a social worker. And if we compare this to only 22% received psychological support, and I believe it was 7% received support from a social worker, there's a real gap there. I think there needs to be a stronger focus on the psychological effects of cancer in adolescents. Cancer was something that really affected my adolescence, and it took me a long time to work through. And that's it from a survivor who's now 34. So what are the risk factors for developing? Do we know anything, late effects, psychosocial late effects? Do we know anything about that? We do know that there are some clinical factors that put some children more at risk of others. This can include their actual diagnosis, Children with hematological malignancies versus solid tumours don't do as well. CNS tumours and sarcomas. Depending on what treatment they receive, that can impact and place them at higher risk, such as cranial irradiation at a younger age, receiving anthracyclines, transplant as a teenager as opposed to a child, and brain surgery. Some demographic factors are known to be risk factors: being female, from a minority group, an only child or a child from quite a dysfunctional family, or someone with poor social support. Other factors that can impact us and our psychosocial health is our physical health. Disability and chronic illness can certainly burden us. Cancer-related, other cancer-related sequelae, obesity, especially the BMTs, fatigue, lack of insurance, inability to work, especially due to a disability, and sleep problems. We all know how important sleep is. So, if we know all of this, and we also know that today, over 80% of children diagnosed with cancer will survive. It is the most probable outcome. And this is something that we celebrate. However, more than 54% disengage from care. They do not return to the survivorship clinics, and we lose them to follow up. This is not unique to Australia. It is an international phenomenon. My team and I recently wrote a report. This is the graph that I was talking about earlier. As chronic health conditions increase, which is the yellow line, visits to the cancer centre actually reduce. And so it's, everyone comes off treatment, is still quite connected to the hospital, is still quite invested in remaining engaged. But then unfortunately, it does drop off over time. But this is when we see more chronic health conditions are emerging, and it's really, really important to stay engaged. But in Australia, as I said, 54% of our survivors do disengage from care. Around the world, that is about an average of 42% remain engaged. So I guess 58% drop out. So we're very similar to the world average. But we know that those who do remain engaged in care receive more regular surveillance, more late effects are detected, diagnosed and treated. They have better late effects knowledge and fewer emergency department visits and hospitalizations. So we are developing new research which is designed to address psychosocial needs and keep young survivors engaged. It's a nurse-led program that allows survivors to have their case reviewed by the specialist nurse. She then takes that case to a multidisciplinary team meeting. The panel discusses the case, creates a very detailed and personalised survivorship care plan, writes referral letters, writes a letter to the GP, and the nurse feeds all of this back to the survivor. And in that way, for many of our survivors who don't live near a capital city, and it isn't easy for them to just stroll down the road to Sydney Children's Hospital, Australia is a very large country, we're hoping to keep them engaged. And in this way, if they do have psychosocial needs, we can refer them and support them in that also. We have some preliminary data back from our Engage program, and a lot of people are saying, I was really struggling with finding the assistance and advice that I needed to manage my cancer aftercare as an adult. And it's really, really reassuring to have someone to talk to about my concerns, about my past medical history and my current and future health. And that it was a really great program to do remotely. And we're definitely hoping through engaging everyone, we're able to triage them more into programs like Kate is going to talk to you about in a moment. But definitely recognising that we need to address psychosocial late effects along with all of the medical late effects that we often see at clinic. So that's about it from me. I'm going to unshare my screen and pass you over to Kate. Now, if I do a new share, oops, I'm just going to not do that. I'm just going to, Kate, can you overcome me?
I think so. I think if I start talking, can you hear
Pause
me?
my share maybe?
This will stop. I think I can override you.
That's looking good.
Success.
And I've got to get rid of mine, I think. There, I think you're good now.
Can you hear me?
I can.
Oh, you can? Okay, cool. Sorry. Okay. Well, thank you, Jordana. And thank you. Just wanted to add to Jordana's thank you to say, yeah, we really appreciate the opportunity to meet with you sort of over the internet and talk to you across the sea about some of the stuff we've been doing, share some of the ideas that we think might be applicable to what you guys have on your plates at the moment. So my name is Kate Hetherington, and I'm a psychologist and a researcher in the same team that Jordana's part of at the Behavioural Sciences Unit, working with a kind of a fabulous group of researchers looking at a range of issues related to the psychosocial impacts of childhood cancer. And Jordana mentioned, I think in passing, my talk sort of flows on from hers, but hones in a bit more on some of the psychological challenges for parents in the period early post-treatment. So in that period, just after sort of treatment finishes. And I'll also talk through some of the support or one particular program that we've developed to support parents during this period, that we're working with Teresa and the rest of the team at CCF New Zealand to hopefully make available to you guys in New Zealand soon. So I guess the period at the end of treatment is characterised by a real sense of relief for parents, which it's what they've hoped for, it's what you guys have worked towards and really kind of being focused on in many ways. So it's a real milestone to be celebrated. But we also know from listening to parents' experiences of this period that things after treatment can be a bit challenging, and kind of the simple idea of going back to normal isn't always like an accurate description of their experience. So you can see this illustrated visually, kind of what we mentally think might happen and then the messiness of reality. And these quotes here from parents just articulate different experiences of this early post-treatment period. So when we first left, you felt like you were being kicked out from the hospital, that is. I'm home, I should be so happy, and I'm bawling my eyes out. I need someone to say it's okay to feel like this, and it's normal. Released from the hospital, it was like being let out of prison, basically. There's adjustment time for the family and doing things, getting back on top of things, and it's not immediate that it gets back to normal, which I think is everybody's expectation. So we've got a list here of some of the things that may naturally change or necessarily change while families focus on getting their child through treatment. I mean, it's not an exhaustive or comprehensive list, but we really just have it here to demonstrate sort of how broad-reaching the sort of adjustments and changes that need to be made during the period of focusing on getting a child through treatment, how broad-ranging those changes are. And it really kind of helps, I guess, develop this idea that when there's been changes in parental work, possibly where different family members are living at different times to enable access to hospital care, relationships with family, relationships dynamics within like a partnership, having time to look after yourself and do the things that you might normally enjoy, having missed out on certain things, both for your children and for you, and impacts on diet, impacts on sleep. And we could extend this list, but when we put it there like that, this kind of see how disruptive the treatment process can be, it really kind of helps to, I guess, make sense of the fact that then getting back to normal when treatment ends is going to be a bit of a process and potentially quite a challenge, and a sort of a transition that many parents and families will benefit from support during. So we've also developed this idea that it might be useful to think of getting back to a new normal rather than sort of just back to normal. Just that slight distinction. This slide here is really just designed to illustrate, again, the kind of mental shift that can happen at the end of treatment. So parents, while focused on their child's cancer treatment, are really in survival mode, getting through the day, sort of dealing with what has to be done most immediately. So using that very practical, organisational focused, kind of a narrow focus part of the brain. And then at the end of treatment, what can happen is that immediate threat can kind of let up a bit. And so finally parents report having a bit more time to think and a bit more time to process what they've been through, what's happened, what the implications are for going forward. And sometimes at this point, just having that sort of slight, like, letting up, or that slight increase in mental space can mean that parents find that at that point they can get sort of flooded by the thoughts and processing thoughts and emotions of what they've been through and what their child has been through and what their family has been through. So these are the things that we know from research in the area, as well as from clinical experience, that parents can be up against at the end of their child's cancer treatment. I think Jordana touched on some of these, but many parents report having really strong fear around possible relapse and anxiety related to that potentially. Generally, the literature suggests that decreases over time for parents in relation to their child, with kind of ebbs and flows tending to increase again around scheduled tests and surveillance type appointments or monitoring appointments. Parents also report a sense of isolation and loneliness at the end of the treatment period, and this can be driven by a few different things, as kind of captured by some of the earlier quotes. That kind of reduced contact with your child's treatment team can leave some families feeling a bit cut loose and a bit isolated. The treatment team have, often been really kind of closely involved with you and your child for possibly really extended periods, and you may form really close bonds with those people, and then that relationship shifts, and so that can leave some parents feeling a bit isolated and lonely. And there can also be parents talk about a sense of distance or lack of common ground with their sort of pre-cancer friends, or the friends and even family who haven't been involved in their cancer journey, just feeling like the common ground isn't necessarily there in the way that it was at the end of treatment. And so having to kind of figure out how to approach that. Parents also report substantial unmet needs around information about managing relapse surveillance, and this interplays with kind of fear of relapse and how to go about getting the balance right. Parents can experience worsening quality of life and symptoms of anxiety and depression, helplessness. But I guess it's worth saying that levels of distress reported by parents in general aren't as high during this period as they are around sort of diagnosis and the on-treatment period. So parents can find this period a real transition and really challenging, but it's also, for many, a transition that is not unlike other kind of periods of time during the cancer trajectory. And I guess I don't want to overwhelm you with the sense of doom and gloom. It's not. And for many parents, it will just abate. For some parents, if they don't get the support they need, it can continue. The research does tell us that there's value in parents seeking the support they need to look after their own stress and distress and mental health, because of the also flow-on effects within the family, because of the potential for parent stress and distress to be kind of associated then with their child's ability to cope and adjust post-treatment. Both the child who has had cancer and the other children in the family. And we also know that parents who live in rural and remote areas may be particularly susceptible to such negative outcomes. And as Jordana mentioned, one of the real goals of our unit is to make the supports that we develop accessible across kind of daunting geographical distances. So that's something that we've been keeping an eye on. But I'll talk to you. I'll come back to that in relation to the support that I'll elaborate on, which is the CASCADE program. So the CASCADE program is something that we developed specifically for parents of children who have successfully finished cancer treatment, and in that initial period after finishing treatment. And it focuses on improving quality of life and reducing distress, psychological distress in these parents. And it basically aims to do this through connecting small groups of parents and enabling them to kind of get together and share experiences, talk to other parents, and also learning particular skills and new ways to deal with these challenges that we know can come up during this period. And it's worth me saying that it's not designed for parents necessarily who are distressed. So you don't have to be sort of feeling distressed or psychologically kind of overwhelmed in any way to participate in the program. It is as much about supporting parents who are finding aspects of that transition a bit challenging and distressing, but also it's about preventing the emergence of particular difficulties by sort of acknowledging that it's a hard time and getting in there early. The CASCADE program is specifically designed to run online, so using technology like Zoom. And as I said, small groups of parents facilitated in real time, and it's 4 sessions or 4 weeks of meeting together for about 90 minutes. And the focus is really supportive discussions and some skills training, and it's informed by a cognitive behavioural approach. I'm just going to give you a brief overview of the program, really for 2 reasons. Some of the skills and ideas might be things that you find useful and might want to kind of just play around with or kind of pursue. But also, as I said, we're working with CCF New Zealand to try and make the CASCADE program available in the near future. So if it is something that, after hearing a little bit of an overview of what's involved and what the approach looks like, if it does feel like something that you might be interested in, then by all means keep an eye on the CCF sort of communication. So the first and second sessions of the CASCADE program really focus on normalising parents' experiences in a way that only other parents who've been through a similar experience can. And we certainly acknowledge that every parent and every family and every child's experience of cancer is different. And that always comes out in groups as well, but there is common ground and a sense of like shared understanding of some of the real challenges that parents can't get with other support. We do a bit of unpacking of some of the sort of potentially laden terms around childhood cancer. So what does survivor mean? What does cure mean? What does getting back to normal mean? And in these first 2 sessions, they've got quite a practical focus on sort of getting back into activity, so self-care and activities that we can kind of, as parents, engage in to look after ourselves. we use this burnout cycle as a bit of a helpful model to explain sort of patterns or cycles that parents might find themselves in after the illness experience. So really just a cycle of having attention focused on your child, of doing what needs to be done, that kind of survival mode, and that letting go of some of that kind of self-care or downtime or just the stuff that you might have had in your life before kind of the focus got narrowed and became treatment. And that not having time for this self-care kind of activities leads to increased stress and decreased energy, and that increased stress and decreased energy can actually make it then harder again to get back into or do stuff that actually you enjoy, or helps you to stay calm or relax, or even gives you a sense of achievement. And so doing less of those things, again, there's less opportunity to have those positive emotional experiences, and you can get stuck in a cycle that leaves parents at risk for burnout. So it's an awareness of how that cycle can kind of can be self-perpetuating and can characterise the cycle that you're in when you're managing and focused on your child's treatment. And so at the end of treatment, it's in the program, we basically in a structured way get parents to reflect on current patterns around the activities that they're in. And they're in three broad categories of activities that we know are really important in terms of managing mood and anxiety and stress level. So it's activities that are either achievement focused, so they give us a sense of like mastery and being on top of things, or activities that give us a sense of connectedness and closeness with other people, or just joy. And in some ways, looking at this material, I'm always struck by how it's quite straightforward and sort of in some ways quite obvious. So it's not that in doing the group we expect that parents, haven't come across this or thought about this themselves. I think the function of getting together as a group and kind of reflecting on what we're doing and then making it a priority to experiment with sort of re-engaging in particular activities if we notice that we've dropped them and that probably has consequences for mood. It's really about kind of creating space to do that and acknowledging its potential for managing our emotions, and also just giving kind of permission and prioritising doing some of that stuff. Session 3 changes tack a bit and is very much focused on managing difficult thoughts that are common to the cancer experience. So it covers quite a lot, and people might be familiar with some of these ideas that sort of underpin cognitive behaviour therapy, but there's basically 2 broad sets of skills that we cover in the program, and parents have the opportunity to workshop with each other and the facilitator, and also then practice at home. And the first set of skills are thought challenging, so recognising thoughts and recognising sort of what are called like thinking errors or thinking biases, and these can be really useful for sort of applying to everyday sorts of worries that we all have. So times when we might have a repetitive thought, or a thought that tends to come up that's not very helpful for us, and we're kind of putting it under the microscope and having to think about, all right, what's the evidence for this, or how helpful is this to me, can kind of take some of the wind out of it. So a structured way of sort of applying those skills. And then the second set of skills, which are probably more important in this context, are skills that we know are useful for responding to some of those, or coping with some of those really scary, these bigger existential thoughts around like what ifs and things like fear of relapse and fear of cancer recurrence that lots of parents experience, and quite understandably, and that can be really hard to challenge, like logically. So we cover some mindfulness and acceptance skills in quite a practical, experiential way to give parents some tools for if those thoughts are coming up and you notice that they're driving stress or anxiety or feeling really kind of hopeless about things, that you can, you've got kind of a set of tools that you can experiment with responding to those sorts of bigger existential thoughts with. And then session 4 focuses in on skills for navigating relationship concerns after treatment. So we know that treatment can put relationships under a lot of stress, and in some cases it brings people closer together, and in some cases it creates real challenges in relationships, and that's kind of in partner relationships, family relationships, relationships with friends, because support networks become really important. There's the potential for them to either be like driven closer together or the opposite to occur. So the focus of this session is really to identify difficulties that people might be having in relationships, as well as common communication traps that people might be falling into in how they're negotiating relationships, and particularly relationships under stress. And we use one of the ideas that we cover and experiment with applying is the kind of continuum of aggressive, assertive, passive communication. So people might be familiar with this idea, but it's basically that when we're communicating aggressively or behaving aggressively, we're kind of holding our needs front of mind and subjugating kind of the other person's needs. And when we're communicating or behaving passively, then we've got the opposite imbalance. And assertive behaviour and assertive communication is a really kind of fine line to walk, but it's balancing, first being aware of and then balancing those things. So we sort of talk about this as a useful model for perhaps having some difficult conversations, if that would be helpful. And we use this in combination with some of the other skills that have covered earlier in the program, so managing some difficult thoughts that might have come up. And we use a sort of model of identifying relationship goals in terms of how it might be useful to apply these skills. So having reflected on what's going on and what you'd like to achieve as a participant, and thinking about how you might use this stuff. In terms of the CASCADE program, we're in the process now of writing up the outcome of a recent evaluation. So just some kind of early indications. The vast majority of parents rated participation as beneficial, and the majority rated it as not at all burdensome. And when it was burdensome, it was typically about trying to find that time to carve out and coordinate with a small group of other parents to make space to kind of cover these ideas. Here are some quotes of participants who've done the CASCADE program, just to give you an idea of what they thought at the end. So it provided me with insight, reassurance, and equipped me with some very useful skills that I can use going forward. I really enjoyed seeing the other members in the group on a regular basis. I was interested in all of their experiences and felt that my concerns were validated by sharing both mine and their stories. It was very nice to connect, to be listened to, and to be understood. I've enjoyed it. A brilliant and supportive program that addresses the isolation and worries that arise in the post-treatment phase of the cancer diagnosis. Many thanks for giving me the opportunity to participate. I've certainly gathered some valuable new skills that will help as I continue the quest of navigating this extraordinary and often relentless journey. So as I've mentioned, our mission is to make this program available in an ongoing way to parents in Australia and also New Zealand. And we are in the process of sort of negotiating, making that possible. So if it is something that you think with you and you would like to be part of it, that you feel would be beneficial, then please, as I say, keep your eye out as far as communication from CCFNZ. And just before I finish, I just wanted to say thank you to our funding bodies who've made development, implementation and an early evaluation of this program possible. And on that note, I think I'll stop sharing my screen, and Jordana and I are very happy to have a go at addressing some questions that we've had.
I don't know how to get can you hear me, Kate?
I can.
Okay. And then if I do start video, I think the host needs to put me back up. Oops. Oh.
I think if you like re-watch your video and then
I press this button. It says the host has asked you to start my video. Okay, hi everyone again. I know there is already one question down in the Q&A panel. Is the Re-Engage program available in New Zealand? No, not at this point, but we would love to share it with you guys. We are having great success with it. We've only pilot tested it so far. We're in the middle of a randomized controlled trial / implementation trial at the moment. But yes, certainly at Sydney Children's Hospital, on average, families live 230 kilometres from Sydney Children's Hospital. So it is a burden on them to come back. And certainly we have had a few survivors come back who on average they were reporting 10 comorbidities, 10 late effects, and so they really appreciated the hospital level care to help with the complexity of their care and really set them up again and educate them around what things they needed to be screening for, and so forth. Yes, I've lost my train of thought, but so they're finding a great benefit from it and would love to share it with New Zealand, but as of yet, it's not available.
Well, I just noticed another question pop up, which was, oh, go on.
And we had a couple sent to us beforehand also, didn't we, Kate? So we can talk about them if you'd like.
How long has the CASCADE program been going? So there was a pilot initially, which I think started in about maybe 2014 and concluded maybe 16, and then an RCT from about 2016 until late last year. So what's that? Quite a few years. Technically, yes, but so it's gone through two versions, so the pilot and then the RCT version, which we're very excited to be sort of crunching the data on the RCT now, and we should have out sort of some part by the end of the year and some sort of first half of next year.
Do you have a copy of the questions we were sent, Kate?
Yes, I do. Well, I've written like an annotated version. So one of the questions was about the impact of steroid treatment, I think over a fairly extended period, over 2.5 years, on behaviour, particularly understanding of consequences or poor understanding of consequences, whether that could be a link, and whether the steroid treatment could have impacted brain development, and just seeking advice for the parents of this child about any ideas for management, and also for teachers, I guess, around management. So there's a few elements to it, and I guess Jordana and I had a bit of a chat about this just before we started, and I guess we had there's a lot in it, and we sort of thought probably the best advice we could give would be to have a chat to, if you can, one of your son's treating like oncologists about the link between the steroid treatment that he had, or the potential link, and behaviour. And in terms of, it sounds like whether or not the steroids are driving the current kind of behavioural issues or current difficulties with appreciating consequences, there are some challenges for you with that. And so we thought it might be helpful to have a proper assessment done locally by an educational psych or a neuropsych, if those sorts of services are accessible. And that seems like a good fit for the sorts of behavioural problems that he's presenting with. and use that to inform management. Did you have anything to add, Jules?
No, that sort of sums it up. Just check in first with your oncologist, with the oncology team if you can, because I think anyone outside of cancer will be reluctant to say with any definitive confidence whether there's a definite link or not, and we can't do that because we have so little information about your son's diagnosis, treatment, and what's going on for him now. So definitely encourage you to get the right information from your oncology team if you can, and then depending on what they say, either go to a neuropsychologist or a clinical psychologist, depending if there is or isn't a link there to treat it accordingly. But definitely encourage you to seek those answers from the people who can provide you with the correct information, and to get the support you and your child need. Early intervention is always better, and certainly have the confidence to ask those questions, and we wish you the best of luck with that.
Yeah, and get that sort of specialist assessment and treatment recommendations or treatment plan. The other question was around if my son finished treatment before he was 1 year old, he's 3 now and doing really well, could he still have psychological late effects? Don't know how I've got this one, Jill.
It's very hard to say, and what we discussed was that it might, well, I did go over some of the risk factors, so I don't know if you could relate to any of them or not, in the treatments and particular malignancies that he had, but also that no, not everybody develops psychological late effects, and he was very, very young. It was probably you that is going through more PTSD than him. So make sure you find support for yourself as well. And that possibly more of the impact might come depending on how the family and the hospital frames his experience for him. And other things like how many late effects, what his quality of life is, if he's experiencing a lot of late effects that make it very obvious to him that he did have cancer, versus if he doesn't and he lives a very healthy life, and it's all, everyone can feel like it's definitely in the past. So yeah, would you agree with that, Kate?
Yeah, I think it is a bit of a, not necessarily, and I wouldn't kind of approach it like feeling like,
it's a foregone conclusion or something. Yeah.
Right. That he might not, but he might. And I think, as Jordana emphasised in her slide, comparing sort of symptoms of anxiety and depression in childhood cancer survivors with the healthy controls or whatever they were called, that psychological challenges are quite prevalent in the general population. So even if down the track he does go on to have some sort of psychological challenges at different points, they may well not be linked to childhood cancer anyway. So yes, I think we can't know, but I think the fact that he's doing well, I'd embrace that and just approach it, hoping that it continues as it is now.
Yeah. Okay, I might read this one out. Oh, hold on. That was the one. There we go. My child has been off treatment for 18 months now and she's doing really well. I feel it would be really beneficial for families to stay in touch post-treatment, and the programs you're offering sound like they would be really useful. I will encourage CCF to continue to explore ways of bringing this support to New Zealand families. You love the Australians are always welcome in New Zealand. Come on over. Awesome.
Thank you. I think when peer support works, it's an enormously powerful and valuable resource.
Okay. Sorry, okay. We've got another 2 questions. Are you able to please give us an example of some of the mindfulness and thought challenging techniques you promote in Cascade?
Sure. Off the top of my head, no, I can't remember. Thought challenging. So if you're familiar with thought challenging more broadly, a lot of the same kind of ideas are covered in Cascade. So, for example, we might get parents to reflect on kind of the sorts of thoughts that are coming up that might result in feeling, let's say, anxious. And so the first step is always putting them down, and that, as much as that sounds simple, that can be quite a challenge in and of itself. And then one technique would be putting it under the microscope. So what's the evidence for this, and kind of putting some parameters around what counts as evidence. So, you know, like feelings, for example, aren't evidence. So it might be trying to come up with like very tangible evidence for a thought and against a thought. So that might be one sort of approach. We also have like quite a comprehensive list of what are called in cognitive behaviour therapy cognitive errors. So tendencies like if you might be in a pattern of catastrophizing thinking. So like, I mean, in a childhood cancer context, it might be like very understandable stuff. Like, let's say your child has like a very common symptom, but that, you know, was linked to their cancer diagnosis back when they were diagnosed, and that every time that symptom reappears, the thinking that follows for you as their parent is like, you know, worst case scenario really quickly. So I might be just starting to recognise those thoughts and recognise that pattern, and then catching it and coming back at it with some sort of challenging thought, like just, I guess it might even be saying something like that. I know why I'm feeling anxious. This is the sort of symptom, you know, my child had initially, blah, blah, blah. But kind of trying to challenge the catastrophic conclusion that you might be automatically jumping to. And then mindfulness and acceptance. We actually do a bit of mindfulness practice in the group, and I don't know if that's about kind of, takes a bit of explaining, but it's about like an awareness of your attention and your focus, and then redirecting focus or refocusing on particular, it might be on internal or external stimuli, and so that is a way to disengage from just being caught up in thinking. So we practice some of that. That's probably, there's a few examples. There's actually even more. It's quite content heavy. It's quite a lot that you can cover. All of these things are techniques that you could spend a lot of time investing in, like each one individually. So it is a bit of a kind of a cook's tour and a touching on a lot of different options. But
Great, wonderful, Kate. Thank you. Another great question we have here is, my son has just turned 19. He was almost 6 when he was diagnosed. He ended up having total body radiation and cranial radiation along with chemo. My question is there any research information around damage that might have been caused that contributes to mental health issues, i.e. depression, that he and others like him are dealing with? So yeah, one of the risk factors in my talk was acknowledged to be cranial radiation is a risk factor for developing depression. It sounds like he had a really tough time and went through quite a lot. And I'm going to, having said that, again, pass over to Kate. Maybe you could mention Recapture Life, although that might be it's another intervention we have that's been designed specifically for cancer survivors. Yeah. What age is it appropriate for though, Kate?
Well, there's another program, as George mentioned, called Recapture Life, which has recently, over the last couple of years, has been rolled out and is being offered through Canteen. But we're also very close to offering it for young adults, so not limiting it to just broadening the age range. Actually, young adults defined as, this makes me feel good, up to, I think it might even be like 39. So through Cancer Council New South Wales. So if you thought your son might be interested in engaging in a program like CASCADE, but for the survivor themselves, so it's the same small group, similar techniques, it's slightly different structure, like the length, the details. But if you thought he might be interested, I'm not sure if Council New South Wales is limited to offering it to people in Australia, or if it might actually be accessible to you guys in New Zealand. So it could be worth checking out. It's due to be launched there imminently, so maybe keep an eye on the Cancer Council New South Wales website. But I could also, at my end, suss out if it is open to people from New Zealand and let Teresa know. And she could,
or maybe send a quick little email to Teresa so we know how to find you and pass you some. We'll get off this webinar and we'll go find some information for you, and then we can shoot it through Teresa to you if you're happy to do that. So please maybe let her know who you are and we'll hopefully find you.
Yeah, because I think it's probably like there's a whole range of factors that could be contributing to mental health, and some of them may well be related to treatment, but then also like the environmental and experiential stuff that's been happening since. Do you want me to read this last one? Looks like it's probably for you, George. My son was treated for HR neuroblastoma at 6 years. He's now 14, and we are now dealing with growth and development issues due to testes failure. I've requested a referral to a psychologist because he's clearly upset but not good at communicating his thoughts and feelings, but told the waiting list is horrendous. So while we're getting good support for the late effects, the access to support for the associated psychological issues is lacking and doesn't feel like a priority.
Yeah, that's tough. That's really tough. Waiting lists. I know it's very difficult because I've had a lot of feedback from people saying we went to a psychologist, but the psychologist didn't even really get it, and we spent half of the session trying to paint the picture for them for what treatment was like and what life after cancer for a teen is like as well. It's sort of, puberty is embarrassing enough as it is anyway. And whilst a lot of good psychs, there are the tools are common across everything. I have heard of experiences where they've spent so much of their time just explaining and painting that picture so that the psych could understand. It's very difficult. I don't know what to suggest because maybe it's just a case of saying, I understand, I get you, you're not alone, a lot do. I don't have a psych in my back pocket. I wish I could give you one. So I guess I can just say, hang in on that wait list. It is amazing how time flies. Continue to get the late effects physical support that you need, and the psychological support will come. And we are trying to make it a priority. And certainly I want to do a shout out for anyone who's ever been involved in research studies. Thank you, because they are the one time that your voice gets translated into evidence, and then we can use that to go to granting bodies and funders to fund the development of these programs, and not only fund the development of them, but then get them into usual care so that people beyond a research study can access them. So we'll just keep trying and keep going.
Yes, thank you. And I can see you've sent through your email address, Catherine. So I will file, I'll send you through. I'll suss out what the situation is with access to that program and send that through. Detail through.
There's another one. Oh no.
I think that's.
Any.
Cool.
We might have gotten there.
Yeah.
Okay, going once, going twice. It feels very odd not being able to make eye contact with any of you.
Yeah.
But all I'm very bad.
You're out there. Yeah. Oh.
Teresa,